but I thought we'd actually open it up to conversation. Any questions that you had for my two colleagues here or myself about what we've just talked about, or anything else you want to talk about? Yeah.
What would the cost of these two bills be in effect? And I don't think that they have anything to offset the costs if there are. And I don't know if we have CPOs.
The back of the envelope is about $9 billion over 10 years. And so relatively, it's an investment, but it's a relatively small investment, giving a $2.7, $2.8 trillion healthcare investment in this nation.
I realize that the purpose of this meeting is to talk about extra medical education and funding for it. But I was wondering about the role of mid-levels in the delivery of primary care, and if similar efforts are being made to build that up also, because a lot of primary care doesn't require 4 years of medical school and 3 years of graduate medical education. I wonder about that side of things.
Yeah, I think you're absolutely right. We're trying to figure out how, and this is going on in practice, that we've got so much tension to get into an oncologist's office or another specialty that a lot of our institutions are now trying to figure out how do we take a patient with cardiac disease, hypertension, give better direction to a primary care physician to say, look, you can take care of this. We've modified the meds. Keep them with you. Here's when you should call me. Giving copies of those things to patients as well, so they understand when they need to see a different specialist. But then the primary care physicians, I think, also have to think about what is it that they're doing. If they've got to take care of these more complex patients, these baby boomers that come in with 8, 10 illnesses, what can they pass on to other people, right? So, but even, I think this goes even further down. With a nurse practitioner or a physician assistant, maybe they are seeing things now that could be seen by an RN or a social worker or a clinical pharmacist. When I trained, and this was, I finished 15 years ago, we had embedded in our general medicine clinic a psychologist who was available to us, a doctorate of pharmacy who was 10 times as good at me at explaining anticoagulation medicines, at explaining how to use asthma inhalers. We had a social worker there as well, because so much of what we deal with in medicine and in primary care is social in nature. So yeah, and in those other areas, I think the number of NPs in the last decade they've doubled, almost doubled their production, PAs similarly. The challenge is we keep turning them out and there's just not enough to meet the needs out there. And there's also, we're thinking about, even in oncology, I know with my dad, both my parents had cancer, and I remember going to see the oncologist, a wonderful oncologist at Johns Hopkins. I didn't see him. I saw the nurse practitioner for the first visit with my dad, and it was great. She could spend a lot of time with us before we met with a physician. I don't know if you want to talk more about what you're seeing in oncology, Susanna, and then also perhaps what you've seen in your own educational experience.
Yeah, I think, excuse me, the comment that Atul made, hold on, is absolutely right. I think a lot of it is figuring out how, what's the proper workload distribution across the providers and the team. And it's helpful for us to have increases in nurse practitioners and physician assistants and other advanced providers as well. And we're trying to work together in the best way possible.
We actually train at USF, when we go through family medicine, we train with nurse practitioners. They're supervising us. And I think one of the great things I was talking with some people at the AMC about earlier today is what I really enjoyed was going in a room with a nurse practitioner and hearing her say, I think I need to go ask for help on this one. This one's a little bit above, my level of understanding. I just want to confirm with the physician, make sure that this is the right choice for you. And for me, that was fantastic training because, one, I'm getting to work with other mid-level providers and getting to see what they do, but I'm also understanding and realizing what their level is, and I'm seeing them come to us and ask for help, and I think that's the perfect collaboration because it should be a team-based approach. But at the end of the day, like we mentioned, we still need more doctors. We still need more nurse practitioners. So I think that there's enough for everyone to go around, so that I don't see that as a competition, I see it as an opportunity for us to work together.
Yes, sir.
I know that VA is already doing this, but what are the thoughts on, allowing nurse practitioners to work independently more?
might not want to bring that up in certain conversations. Yeah, I mean, I think the question is, what we're trying to move towards in medicine is, right now, and I'm sure Alicia will back me up on this, MDs are pretty straightforward in how you earn an MD, right? You show up for 4 years, you're there, you sit in the seat, you go on the rotations, you do your clinical stuff, you pass the exams, and it's like, okay, 4 years later, there's your MD. My PhD, though, was like, it's left entirely up to you, but it's more sort of milestones that you pass. So what we're thinking about in medicine is how do we move towards that sort of milestone and competency-based evaluation and education. So what are the activities we're entrusting you to be able to do? And I think that, the pediatricians are now doing a pilot with 4 medical schools, with med schools, residencies, to figure out if they can come up with those core competencies and let people progress at at different rates. So if some people can figure out how to get the basic competencies in 3 years, don't keep them there for 4. If they can train in 2.5 years rather than 3 or 4, let them do that if they're rock stars, right? And we know that those people are different. So I think one of the logical follow-ons then is if there's a competency in doing well child care, could that be the same for another health professional to say, okay, we see that you can do this part independently, but not everything necessarily. So that's where we're hoping to move. And again, it's a question of getting the right patients to the right healthcare providers in a timely way. So there's a lot of professional conflict around this. It's less of an issue at our academic institutions because, quite frankly, our physicians are part of a system. We have 130,000 faculty physicians out there, and if I say to them, I got a nurse practitioner to help you in your outpatient oncology clinic, or a nurse manager on my bone marrow transplant unit, it's like, bring it on, I need the help, right? So I think it's a very different dynamic when you get out there, but what we try to explain to our physician and other colleagues is there's enough work to go around here, and we ought to figure out what to do, what's best for patients. I don't know if you have anything to add.
I think that's good.
I see a nurse practitioner, so,
Yep.
yeah.
Perfect.
On the GME funding and slots issue there, would it be feasible to keep the amount of spending constant given the kind of budget situation we're under, but increase the number of slots so that, I guess, the payment per graduate medical student or person in the hospital, whatever, would be reduced? Or I guess part of that is, at what point do hospitals and other care centers stop wanting to take on new graduate medical?
We have been able to grow by about a little less than 1% per year up until this point, the numbers of positions. We've done that through using clinical revenue. Essentially, our faculty get paid less than physicians out in the community, and they do it because they want to contribute to research, to training. That's part of why they're there. Our concern moving forward is that we hear from our educators and our teaching hospitals that the way that clinical revenue has been compressed, they don't have the resources to support additional positions anymore. It costs about $145,000 a year to train a physician. You add up all those costs, and we sink about $15 billion a year into their training. Medicare currently supports about $3.2 billion a year. So we've already kind of done as much as we feel like we can. And I think that's why now we're very concerned with an example that Alicia gave about a residency reducing positions. I know St. Joe is out in Phoenix. Right when they're starting a new medical school, they're getting rid of their whole pathology program because they said we just can't afford to keep these residents over the cap anymore. So I think we're at a point now where we've kind of done as much as we can, and we need a little more help.
So you just said over the cap. If the subsidy per student was lower, than you'd expect more people to drop out, even under the cap?
Yeah, I think so. Because it's all sort of, what do you have to support the educational and clinical environment?
I also just want to add on that part of funding the residents, part of that money goes towards research, development, and having trauma centers and the ability to treat patients that wouldn't be treated at other hospitals, like I mentioned HIV just as an example before. So at my institution at Tampa General Hospital, we get all of the patients in the area that have, these burns or these horrible gunshot wounds. So if we're going to be decreasing the funding, it's not just going to affect the number of residents that we have, it's also affecting the ability to treat serious injuries at those hospitals.
Yes, sir.
So, yeah, absent another avenue to pay GME or to pay teaching hospitals, seeing that that's also the bottleneck, there are more applicants for this cycle than ever before, right? And the return on investment for matriculants, then, I mean, obviously they think it's worth not only the years of work, but also, it's a good return on investment for them. Is there any way to shift, say, I mean, obviously there is a way, but, to essentially milk it from them and say, well, it's worth it to become a doctor,
Yeah.
maybe that money should go. to
And
the
traditionally, when people were residents, they resided in the hospital. You didn't pay them anything. And I think certainly if you said, well, we're going to make the learner.
Well, I'm not saying not give them a living wage. I'm saying things like.
Or charge them tuition for residency training?
The National Health Service Corps, things like that.
Yeah, I mean, I think that the core is great. It doesn't help us support the overall increase that we need. And if you do talk about putting more of the burden on the learner in some way, I think what we worry about is that we already have a problem in medicine where most of our med students come from the top 20% of socioeconomic status. They come from, families with resources. And we're doing all we can to get a more diverse group of individuals with different backgrounds into medicine. And we worry that if we put more of the costs on them, are we really going to make that problem worse? Or if you say, well, if you go into cardiology or oncology, then you have to share the cost. If you do something else, you don't have to. That gets a little tricky.
I would definitely like to respond to this one. So, it's an excellent question. I've been asked that one a lot when I go out and talk to different groups. And I want to explain it this way. I was not one of those lucky people to be the top 20%. My father is a police officer. My mom teaches high school. My dad worked double overtime so that I could go to college. My brother's now a junior at Florida State. And my mom has been severely ill, and she worked the entire time. I mentioned she's in the hospital now, partly because she worked and didn't take care of herself when she should have, so I feel very guilty for that. But in order to go to college, we had to put a second mortgage on their house. I worked 3 jobs while I was in college. The average medical student, and this is a bimodal distribution, so 2 humps, the average in between there is $167,000. So if you come from a family that has more money, you're in the lower hump. If you come from a family like mine, you're in the bigger hump. So we're talking about a significant amount of money that you owe when you get out of medical school. Next week this is embarrassing, I turn 30 next week, and I don't have a job yet. And I'm applying to a residency program that's 6 years. I'm also applying to general surgery programs and considering doing a fellowship in plastic surgery. So we're looking at 36 to 38 when I graduate and I get my very first job. Am I going into medicine for money? If I did, I was very stupid and foolish with my life plans. And I would say that the majority of my classmates make the decision to go into medicine because they really want to help people and because they are passionate about it. There are a lot of friends going into family medicine and they're saying, I'm not expecting to be a millionaire. So when you say, should we pay for it? It's not a question of should we, it's a question of how could we possibly. There's no way I could afford to pay to go to residency. Many of my classmates that are in residency now they're struggling to get by. If they have children, they can't afford to make their payments. None of them own houses. I don't have a single friend that owns a house. They're all renting very small apartments. So I think what would happen is you would see a huge trend of the best and brightest not going into medicine.
We're talking about the SWOT numbers. Are you guys looking at any even larger reforms to GME and how it is provided? MedPAC seems to be pretty clear that there's some room for reform in the program. Is there any way that we can get some savings out of that, or?
Yeah, one of the bills that we've endorsed is HR 1201 from Mr. Schock and Ms. Schwartz, and there's an attempt in there to really try to address MedPAC's concerns in terms of reports around transparency and looking at diversity, but also tying some payment to the things we want out of our health professionals in the healthcare system. And those would include, are we training in teams? Are we training in different locations, not just in a hospital? Are we training people about how they use information and IT? Are we training them to think about the relative costs and value of different therapeutics and diagnostics? I think we're doing a pretty good job there, but we don't mind being measured in those areas. Where we disagree with MedPAC is they wanted to put 50% of funding at risk, potentially, year to year. Now, I can't train a surgeon year to year if I don't know the funding's going to be. I can't keep a trauma center open if I don't know if there's going to be resources the next year to train trauma surgeons and keep the trauma center open. So what we had suggested that a more reasonable approach would be to be consistent with the rest of value-based purchasing programs and talk about putting 2 to 3% of funding at risk. So I think we're trying to move forward in that direction. We've been supportive of some of the other targeted programs that are in the Public Health Service, Title VII, Title VIII, teaching health centers. All are good things. The VA has done a fantastic job at supporting many of our residents as well. And our faculty are VA physicians in many cases. So, you know, we're trying to move the system forward. The question is, how do you do it in a way that doesn't completely disrupt the training of physicians and other health professionals? Yes.
Speaking of the formulas that have been developed over a number of years for the DGME and IME, they're convoluted, they're complicated. Shouldn't we be dealing with a way to simplify it? For instance, would it be better, instead of giving these funds, GME funds, directly to the institutions, would it be better if they went through the actual graduate medical students, so that the money followed them rather than going straight to the institutions like DGME and IME are doing right now? Or?
Yeah, I mean, I think the rationale ought to be the funding ought to flow to whoever is bearing the costs, right? And so that's the way it works right now. And you know, the hospital is generally bearing the cost of maintaining a training infrastructure, even if you're training, you know, at a place like our members, like University of Mississippi, where they are collaborating with 22 federally qualified health centers. They staff the health centers, they send trainees out there, but they're bearing the cost of the infrastructure. You know, and you have to remember, I think Alicia's point, that the IME is a patient care payment. So again, it's made to adjust the MSDRG system the same way that DISH or outlier payments do. Is it a bizarre formula? Yes. Have we come up with a better way? Not yet. We still sort of see a lot of the cost tied to the intensity of training, because those tend to be the places that are doing more clinical research, running a trauma center or burn center, and caring for sort of more orphan type diseases. But yeah, I mean, we're always willing to, if there's a way we could do it better, yeah, I think that's possible. You know, I don't know, you could walk around with some money on your back and go door to door, but it's a challenge. Any other questions? Yes, ma'am.
One of the other criticisms about allotting slots and the funds that follow it is that it doesn't necessarily keep up with the demographic trends that we see in the nation, as far as where we see the most population growth, where we need additional doctors, but those states aren't necessarily getting additional slots and additional funds. So do you think that there should be more, I guess, more equity in that system of how you allot?
Well, again, this is an artifact of putting a cap in 1996. So if you look at a place like New York, half of their hospitals are teaching hospitals. There's still the ability under CMS regulations to turn a non-teaching hospital into a teaching hospital and get support for those residents. But it's a money-losing proposition, and so if you look at a place like Arizona, there's 17, 18% of the hospitals are teaching hospitals. The other hospitals could become teaching hospitals if they wanted to do it and be supported, have their slots supported. But we haven't been able to convince them to do it. We've redistributed all the unused positions already, and those went to areas in, I think, more rapidly growing states and communities, went disproportionate to rural areas. So we've kind of done all we can in moving them around. The other thing you have to remember is that if I go to a place like Montana, right, there's more physicians practicing in Montana from Washington, California, Oregon than there are that were trained in Montana, because you need a population center. Because even if I'm not going to do trauma. I'm an internist, but I rotated through the trauma system when I was an internist because I needed to understand how that worked, understand if I sent my patient to a specialist. So a lot of this has to be highly concentrated, but yeah, we ought to be trying to get more hospitals to develop training programs. It's just not been feasible at this point. Any last burning questions? If not, I know you've been generous with your time. Thank you to my colleagues for being here.